So now we will be presenting a case of eyelid tumor. I'll be presenting the clinical part, and Dr. Jakati will be presenting the pathology part of the same tumor. So this picture, as you can see, is a picture of an old male who presented with complaints of lesion in the right upper lid. And he had this lesion. It was a very long-standing lesion. For the past 10 years, it was noted. The recent growth was noted in the last 2 years. He was coming for regular examination for his other ophthalmological condition, the retinitis pigmentosa, and he had some significant medical history. May not be directly related to the lesion, but he did have some medical history. His vision in both eyes was 20/50. Now, if we focus on the lesion, so this was the lesion which was present at the medial aspect near the canthal area. And it was purely involving the skin. There was no involvement of the posterior lamella that was noted. And there were no signs of, and if we look, whenever we see an eyelid lesion, what we always want to know is clinically whether it is a benign lesion or whether it is a malignant lesion. And there are certain signs of malignancy that we always look for whenever we suspect, and this becomes important because the management of a malignant lesion versus the management of a benign lesion are very different. Now here, if we see, the patient had no signs of malignancy as such, because there was, the skin was absolutely kind of like, obviously didn't have any ulceration, crusting. The lashes around that area were absolutely normal. It was not affecting or causing any changes that were signifying or that were hinting towards a malignant lesion. So with this, though it was not very cystic, we didn't do the transillumination test to tell that exactly this is a cystic lesion, but we do see these lesions very, very commonly, especially in elderly population, where they need not, though we call this epidermoid cyst or a dermoid cyst, even if we have, they will not have the cystic consistency to them, because they do have the solid component as well. So with that knowledge, we made a diagnosis of, probably because he gave a very long-standing history of 10 years, so we made a provisional diagnosis of epidermoid cyst, and we excised the lesion. Because we did not suspect any malignant lesion, we went ahead and did like a shave biopsy. We took out the entire lesion in that area and left that. It was like a pedunculated area. There was just a small defect which we could close directly. And we sent the specimen for pathology examination. Now, Dr. Jakati will tell us what happened in the pathology lab. Over to you.
Yeah, thanks, Swathi. So what we see here is a solid cystic lesion on a scanner view. And on low power, what we see here is that there are solid islands of cells floating in pools of mucin. And on extensive sampling and on extensive sectioning, we tried to look for in situ areas which were not seen in this particular lesion. The lesional areas was focally solid and also had a cribriform pattern to the in focal areas, and they are traversed by fibrovascular septa at focal places. So lesional cells on higher magnification were mostly monomorphous. Very mild pleomorphism was seen. There were no mitosis at all, and there was a lot of myxoid background seen. And on Alcian blue, the lakes of mucin were highlighted. Both extracytoplasmic mucin and the intracytoplasmic mucin were highlighted. On immunohistochemistry, these cells were strong and showed strong and diffuse positivity for pancytokeratin, EMA, and CK7, whereas CK20 was negative. We also ran a panel for endocrine markers. So NAC was negative, chromogranin and synaptophysin were also negative. Ki67 was around 15 to 20% at focal areas. So we diagnosed this as mucinous adenocarcinoma.
Yeah, so once we have this diagnosis of this being a malignant lesion, there comes always a dilemma for the clinician whether we have to go back and do a wide excisional biopsy, because this patient, since we did not suspect a malignant lesion. We had just done like a complete excision of the lesion. We hadn't taken tumor-free margins. So always we have to think of, if this patient, we have to go back and take wide margins. Now this patient, since we did not, we have time, I guess, right? Okay, since we did not, the patient also was not very willing for a resurgery, because obviously because he had a very good cosmetic outcome, and he was like, this lesion has been there for 10 years and he was not keen on surgery. So this patient, we did not go ahead with a repeat surgery. But of course, it's important for us to know whether this was a primary tumor or whether it was a secondary tumor. That becomes very, very important, because primary mucinous adenocarcinoma is not very common. So we did a metastatic workup, a systemic, rather than that, a systemic surveillance to know if there is lesion elsewhere which has actually presented in the eyelid as a secondary. So this patient did not have any lesion elsewhere, suggesting that probably this is a primary mucinous adenocarcinoma. Now let's move to a second case. Now this, again, the reason that we are presenting this is, now this patient also had the same diagnosis, but the difference being that this patient was a young patient. As you can see on the slide, the patient was only 37 years old, and you already see a scar that is present in the subbrow area, indicating that the patient has undergone surgery before. And if you look into history as well, you can see that the patient has actually undergone 3 surgeries. And the diagnosis was different in different places. So he came with the report saying, in one place where they called it as a chondroid syringoma, other place where they just called it as myxomatous degeneration and a dermoid cyst. So there were different diagnoses that the patient came with, and he had these multiple multilobulated lesions which we could palpate very well. And the posterior extent of the lesion also was palpable. I haven't put the CT image here. He also had a CT which clearly showed that it was not extending deep into the orbit, but it was limited to the eyelid itself. And this patient, again, we went ahead and did excisional biopsy, like a wide excision. We didn't do frozen section for this patient, again, because we did not clinically suspect a mucinous adenocarcinoma. That later itself we came to know after the histopathology diagnosis. We went ahead and did excisional biopsy of this lesion, where the entire lesion, the skin could be nicely separated from the lesion. So we went ahead in a subcutaneous plane and removed the entire lesion. And Saumya will just show us the histopathology of this patient. Yeah. We did not make this diagnosis. He had come with the diagnosis of the pathology. Yeah. So this we just gave, we didn't know exactly what this tumor was. I think we sent to the pathology lab as just adnexal tumor. We didn't know what tumor exactly. Yeah, that's what we just sent it as, like an adnexal tumor. What exactly it was, we did not know. So provisional clinical, we just kept it as adnexal and sent it to pathology lab. The diagnosis that we have listed there was he had come with the reports of these. Over to you, Saumya. Yeah.
So on histopathology, again we saw a similar morphology as to the previous case, wherein there were islands of tumor cells which were very monomorphic, floating in pools of mucin, and they were separated by thick and thin fibrous septae. This is on Alcian blue, which is highlighting the mucin. And on IHC, again the tumor cells were positive for pancytokeratin, EMA and CK7. CK20 was negative. So then we concluded this as mucinous adenocarcinoma.
Yeah, in the interest of time, probably we can skip the discussion part and we can take questions.
So I think few points which we can highlight here is that GATA3 is one important IHC marker which you can do, which is very specific for these tumors. And CK7 positive and 20 negative tumors, 20 profile should always point out that this is a mucinous adenocarcinoma. Endocrine secreting mucin producing adenocarcinoma will be a precursor lesion to this entity. And when the the expression of synoptophysin and chromogranin is lost, then you can have this kind of appearance of the mucinous carcinoma. It's widely extensive, and for metastatic workup, you can also do CDX2 to rule out metastasis from other GI tract malignancies. And systemic workup is always advised. Thank you.
Thank you.
Well, thank you very much for an interesting presentation.